felicitaciones por la belísima charla, pero me gustaría mucho de hablar en inglés para ser más claro. Vou cambiar um pouquinho para inglês. So guys, thank you so much for this kind invitation. Are you checking my screen? I guess you see my screen. Watch my screen. Okay.
Está bien, Rafa.
Perfecto. So thank you so much for this kind invitation. It's a real pleasure and honor to be here. I have good friends. I have some disclosures, but basically in education and HPB and robotic surgery. So I'm glad that Guilherme, present this lecture because he showed something that's really important. It's the standard for the actual the current position for laparoscopic resection in pancreas. This is important, but one thing that the message that we always have to say that it's necessary experience in open pancreatic surgery. One thing it's a big deal in this surgery, it's intracorporeal suturing. This is a big challenge. And also the ability to control bleeding. If you got these three, you can start doing laparoscopic resection for pancreas. This is my view. For distal pancreatectomy, as Guilherme showed pretty well, it's considered standard today. But when we look to the pancreatic duodenectomy, now you got a lot of controversial. This is controversies. This is really important, and we'll discuss a little bit about it. We know that the robotic surgery is increasing. Today, this is what's in the pandemic, like on March 31, and you saw that almost 6,000 robots. In Brazil, we have 74. And it is increasing, especially for general surgery. It's increasing more than urology or gynecology. That's a pretty standard use of robot. And they are, the points that really strong are those, the return of tridimensional view. But also one thing that's important, it's the stability of the image. This makes a lot of difference. But also, as you heard, as you know, that the end wrist, so the movements of the forceps, robotic forceps, are close to the human wrist. So that this is the argument, that's what's said. Today, we still have a lot of data that's no randomized. But you start to have some experts consensus and review. This is a good one. I think that's interesting, but even this one has criticism for sure. But I like to show you because the people are really experienced here, and you can discuss and see some points. So if you have to pick up one to read, this is I would recommend this one. But again, no randomized clinical trials yet. So this is it's important information because for distal pancreatectomy, when you look to robotic versus laparoscopic distal pancreatectomy, and this expert, they say that node harvest it's pretty much the same. The margin is also the same. Intraoperative blood loss is pretty close, so no difference. It makes sense about the intraoperative recovering of the patient because if you think in the hemodynamic point of view, for the patient, it's pretty much the same regarding pneumoperitoneum and also the magnified view of the surgery, but the length of stay as well. So the trauma that comes from the surgery, it's the same for minimally invasive and on both ways. And postoperative complications and fistulas. This is the results when you look to the this consensus and the data that were available. But also that's interesting that they show that the vessels and spleen preserving is better in robo. We got some consideration. That's why I will show it. This is another review that's also interesting when we look to the economics in robo and robots. So this one, it's looking for digital pancreatectomy. If you pay attention here, even including costs of amortizing robot, what's really big, this review show but this study shows that digital pancreatectomy costs less than laparoscopic and even more for open surgery, and it doesn't make any sense to me. So that's why I explored this paper a little bit. When you look here and you saw this kind of patients, as Guillermo showed previously, here you also have a strong selection. You saw no adenocarcinoma in robotic approach. So the easy cases are there, like IPNM and neuroendocrine tumors. So the easiest one goes to robots. So that's hard to compare both groups if they are not the same. But one point that's interesting is that those both groups are, they allow us more, many times to observe the spleen and the splenic vessels. And this is interesting information because it seems that robot, you can preserve more than laparoscopic. And also, and this it could impact some costs or some complications. But let's continue here. When we look to the others, no more advantage in costs. So the robot is more expensive. Even those papers that are not including the cost to amortizing robot, okay? This is a video, one minute video that show, I did this small video yesterday, exactly because I would like to show you a video where I preserve when I preserved the vessels. Here we releasing the splenic vein, and you see just more deeper the artery, and now you start to go over the artery exactly to elevate the tumor. You saw the nodule, the IP. This is a case of IPNM. And you saw that's possible to do, and you do it pretty much as you would do in the laparoscopy. But as soon as you have some articulate motions of the forceps, it's a little bit easier. And this is important, and I like to show you because, you know, if you have both good, why should I use the robot? You know, that's if you look for sustainability of a system and the costs, and in Brazil you have to pass the costs sometimes to the patients. What's the points that you have to show them that's worth or not? So this is seems to be better. Okay, that's my impression, that's my opinion. And we have only retrospective data to support it. So it's a weak evidence. So this we can go a little bit faster because Guillermo showed pretty well. But it's interesting when you look to the Leopard 2, you have 62 patients in each side instead of 30. 68 patients in each site instead of 30. So the power of this study, it's higher, and as you know, it was interrupted exactly because the mortality got higher in the laparoscopic group. It seems they're recovering also no big difference. So again, why should I insist something? Move to robot, what's the point? That I should offer something that's it's better. When we're thinking about the robot, you think that the suturing it's amazing. Instruction, it's the point in the pancreas surgery, minimally invasive pancreas surgery, pancreatic surgery, because the resection it's pretty okay. Okay, you can do it if you don't have like invasion of splenic mesenteric access. You can do it, but however, when you have the suturing with soft pancreas, it's hard. So again, I'm also again talking about that expert, and you saw that, you know, node harvesting, no difference, transfusion, post-operative complications. But here it's harder than the distal, because distal I was showing data comparing robotic and versus open. So it's no fair comparison with laparoscopy and robot. But again, we have also merging better results and merging status, length of stay. Length of stay makes a lot of sense, but merging status, again, intraoperative blood loss, and the only drawback, it's the operative time. But again, perhaps we are not comparing exactly the same patient. So this is a review and meta-analysis. And just like to show an example, when you do a meta-analysis and you did not pay attention in the imbalance between groups, as Guilherme showed the previous meta-analysis looking for from European Journal of Surgical Oncology, when they compared and saw how the patients were selected, that's the correct way. Here, just showing the outcomes. And when you look to the outcomes, operative time, it's bigger. However, estimated blood loss and our zero status are worse, probably because the patients are not the same, okay? So pay attention about meta-analysis and retrospective data. It's really important. And again, the cost seems to be higher. It's higher, clearly, in the robotic, including or not amortizing costs. Cost of amortization. It's better why we should pursue something that's more expensive, and also the laparoscope showing no advantage. What we can do better in robot, that's my personal impression, and that's why I want to state it. If the suture, at least in my hands, are easier doing it by robot, I guess that's better if I can offer it to the patient, because it seems that the result is better, okay? But we don't have data good enough to support this point right now. But here you saw that the movements, it's even through the duct mucosa anastomosis, that's hard. We can do a little bit better with, at least in my hands, with the robo, okay? These techniques, I used to do Blungert. This is another part of the surgery that's also, again, we can do two running suture, one for posterior and another lay. I think that's easier when we do it by robot than you do it by laparoscopy. But again, it's feasible, okay? It's not the most difficult point. The most difficult point is the pancreatic jejunal, but it's nice that you can, you know, calculate better when you have to put your needle and do the suture. So if you have a space in minimally invasive for pancreas cancer, I guess that the future will be more for robot than for laparoscopy. Okay, this is what I think, and that's why I do believe that we have to pay attention about the data looking for robot in pancreas cancer, because probably it's something better. It will show that. And to finish, just to conclude, the minimally invasive pancreas surgery is feasible, but patient selection is mandatory. You still have to do size and disease and needy for node harvesting makes a lot of difference. For lap distal pancreatectomy, it remains the standard. No difference in outcomes with robot, but however, robot is more expensive. And the same for Whipple remains in work in progress regarding complication rates. Lap and Robo, Lap is cheaper than Robot. Robo can improve skills for suturing, and open surgery remains the standard. This is something that you have to say as well. Thank you so much for your attention. We have to get your questions, and sorry about the time.